yeah.
So let's talk, Dr. Harris. Tell me about Cross Care Direct. How I can refer people to you. Tell me exactly what you do and why it's different and how all that stuff works.
All right. So Cross Care Direct is a traditional outpatient family medicine clinic. So I do family medicine as you recognize any other family physician.
Okay.
So primary care visits, chronic illnesses, acute care, prevention. We cover the gamut.
Right.
We even do small scale procedures.
Okay. And when you say small scale
procedures,
to the layman,
things
what does
such
that mean?
as removing moles, taking skin tags off.
Okay.
Small lacerations when you cut yourself, suture you up.
Right.
We freeze off wards.
Okay.
Very basic procedures that nowadays you often don't have time to get done.
Right.
In the primary care office, you have to get referred out to someone else.
Okay.
So that's
so. Do you need a referral to come to you, or
no.
you handle all that?
Nope.
Okay.
Nope. I'm your front face.
Okay.
I'm, as some in the medical world would call, your gate opener.
Okay.
So I'm your gatekeeper and your gate opener.
Okay.
And what I mean by that is you come to me for your services without permission from anyone else.
Okay.
Because you choose to come here and see me as your primary care prevention person.
Okay.
You want me to look at you, evaluate your health, see everything that's going on with you, and decide, do I need to go out to a specialist?
Okay.
Or is that something together that you as a patient and me as the doc can talk about and decide what happens next?
Right.
In addition to that, what makes the model unique, because you could argue, well, what I've described so far is what
sounds
you
like
traditionally get. It sounds
right.
like a normal doctor,
right?
But the key difference in this model is the pay, the way it's paid. Everything else about it is unique. So there's a method to that madness of the name direct care or direct primary care.
Okay.
That means there is a direct financial relationship between the patient and the doctor.
Okay.
So there are no insurance companies. There are no third-party people involved. There's no Medicare.
No
there's
claims,
no Medicaid.
none of that.
There's no claims. There's no get a bill here at the office, get another bill when you get home. None of that. It's direct care, meaning we have a conversation. You agree to pay a monthly or annual fee, retainer, to have me as your provider, to have access to me, to have access to my knowledge, to have access to the care that I provide.
Wow.
That keeps it simple.
Yeah.
And what people never think about is, from a doctor's perspective, the beauty of that and the benefit to you as a potential patient, I don't have to decide how to take care of you based on your insurance.
Okay.
Or your lack of insurance.
Right.
I can literally say to you, I'm going to take great care of you based on the current standards, and I'm going to take great care of person B based on the standards, and I don't ever even have to know what the insurance says or does.
Right.
We don't care.
Right.
That discussion is strictly between the two of us. We get to decide what happens to your health and how to make it happen. That's a very free way to practice.
Right.
It's a very safe way to practice. It prevents me
Seems
from
like it
making
benefits
mistakes.
the customer a whole lot.
Completely. You get 100% attention without any distractions, without any input from anyone else. Everything we decide is because I, from a medical standpoint, think this, and you, from a personal standpoint, think that.
Right.
So we put our heads together and figure out the best way to care for you. Nobody else has anything else to say about it. With that said, you might say, well, okay, I pay you this monthly or this annual fee. You serve as my doctor. What happens if I do need something else? Something that's not covered under these plans as it stands? That's what we have a discussion. Once again, it's a direct discussion between the two of us. And I'll say, Mr. Jameson, I need you to get test A, test B, and oh, by the way, I need you to send you to specialist number 1. We have a discussion about exactly what that costs.
Okay.
Nowhere in medicine does that happen.
Right.
That's part of the issue now.
Right.
With the rising cost of healthcare.
Surprises.
The surprises.
Yeah.
There are no surprises here. You know exactly what a test costs, which, by the way, any test that you get done through this office is offered at wholesale. I don't have to make a profit off the test.
I was thinking that because wholesale you don't have that middleman, it's got to be cheaper in the long run.
Significantly cheaper.
Okay.
I'll give you a prime example.
Okay.
I went to see my own physician year before last. By the time they got through doing the testing, filed it through my insurance, I received a bill where I owed $150, right? It's about 5 lab tests. I decided, let me take it to my office. I'm curious, based on my wholesale prices, what would I have gotten those labs done for in my office without dealing with any third party? $50.
Wow.
That's without filing insurance. That's without anybody paying anything up front. Nothing. It was exactly $50.
A third of
the cost.
Right.
We think sometimes we're getting the benefit, because we have the insurance, but people have to keep in mind
there's a profit there.
There's a profit. Everybody's got to make their cut.
Right.
But if you don't have as many layers in there,
yeah,
and you offer the exact cost savings, you pass it on down to the patient, they realize, wow, that's pretty reasonable.
Right.
I can do that, period. And I'm not disturbing anybody else. I'm not having to use insurance. I'm not having to go and look at somebody else. I'm not having to take a second mortgage out on my house.
Right.
None of that stuff. And these things get taken care of here in the office. And furthermore, you know exactly what's getting done to you and why.
Right.
We have the time.
Because I'm talking to you.
You're talking to me, and I'm telling you exactly why I'm recommending this, and this.
Right.
We talk about what potentially can happen. We also, the other benefit, and that goes back to not only good access, but great quality of care and an open line of communication. When you leave the office, if I'm recommending a specialist and you've agreed to see that specialist, we make sure before you walk out that door, we call and say, what is it going to cost them? Mm-hmm. If it's not going to cost them anything, here's their insurance. Is it okay they use their insurance there, and what is it going to cost them? Mm-hmm. So before you leave my office, not depending on what somebody else tells you,
right.
Before you leave the office, I make sure you're set. If you want me to set that appointment before you go, I do that. I don't send you out the door and say, call him. Right. Call Dr. So-and-so and get yourself in there. That's our responsibility. That's what you're paying for in terms of access.
That's amazing.
It's a true blanket of care.
Yeah.
We take care of the bases.
Right.
We schedule it all. If there's something going on, I have a lady now who's having an issue with seeing one provider. It's a lot easier for her to see a provider that's closer. Mm-hmm. Guess what? We're on the phone now trying to get that patient transferred to this other physician. And if it takes me getting on the phone with that physician and explaining the circumstances, we will do that. Because the better care for this patient is going to be right here where she can best be seen.
Right.
We're going to make sure that happens. The beautiful thing about this setting and this model, I'm your physician, but more importantly, I'm your advocate.
Right.
That's a big deal.
Right.
As people get lost in the healthcare system.
Right.
My patients go in the hospital, I know exactly what happened to them. Mm-hmm. I know what's going on. I'm affiliate through Piedmont. If they say I've been hospitalized, I simply go in the system and I pull the records.
Okay.
I look at it. I follow that along the way. There are some that I even go and visit in the hospital. Right. Depending on what's going on. Mm-hmm. They don't have to fear. I have to actually tell my patients, you do know you could have called me, right?
Okay.
And that's the other difference. Significant difference in this setting and another one. You have access to me 24/7. And what I mean by that is, in a normal setting, that doc goes home. You may get an answering service. Right. You may get a backup doc. Mm-hmm. You may get a nurse. Bottom line is, you may not, or most cases, you will not get your physician directly. Mm-hmm. Our patients here, there's a private app, a HIPAA-compliant app, that they are able to reach me after hours. If they are from afar, they may text. They may send a picture. They may reach out to me by whatever means they need to. And the phone doesn't ring here. It doesn't ring to my assistant. It doesn't ring all over the place. Mm-hmm. It rings directly to my phone. Right. So they have the access. And sometimes it's just reassurance in the middle of the night that, no, you don't need to go to the emergency room. Right. I'll see you in the office the next morning. Mm-hmm. That's the beautiful thing about the way this works. It could be something that happened late on a Friday afternoon.
Rather than wait till Monday.
You can call. There have been occasions I come back up here and I meet you and we deal with it. Mm-hmm. I've had to suture folks at 7 o'clock, 9 o'clock on a Saturday evening. Mm-hmm. It's whatever the need is to keep you out of other systems that are more costly, not only to you, but to the healthcare system as a whole.
Now, outside of the money aspect, why does the general public not know about this? As a whole, I would say.
As a whole?
Yeah.
I would say for two primary reasons. Number one, we're creatures of habit.
Okay.
So if someone comes along with something new and it sounds too good to be true, we're like, there's something not right about this. Right. So we're a little leery in terms of being able to listen to and open up and accept that this is indeed a way that we can take care of many of our healthcare issues. Right. That's number one. Number two, there are others who would argue this is not a fair way to handle healthcare in the sense that people still need insurance. And we don't disagree with that. Mm-hmm. Matter of fact, we encourage our patients to take on us as their primary care physicians because they want the best quality care, but tack on a catastrophic coverage plan. Okay. So that indeed they are covered for the times they absolutely must end up in an emergency room and end up being hospitalized. Mm-hmm. That's a necessity for all folks. Our thought is, why pay an arm and a leg for that same coverage when you're either A, barely utilizing the services,
Right.
or B, you really just need the attention along the lines of primary care.
Yeah.
Primary care is inexpensive if we do our job.
Right. Right.
So why are we paying for this souped up policy to cover primary care, ER, all these catastrophic issues, when we can simply pay for a catastrophic plan, tag on across Care Direct and the other direct primary care docs for a less expensive fee? The annual cost to us, the annual expense, is ultimately a lot less.
Right.
If you do it that way. But we have a weird way of thinking about, I don't know about that.
Yeah.
You know, that's a typical response.
Yeah.
And I like to share it as in, it's what I tell a lot of women. How many times have you ever put on an outfit and everything about that outfit came from the same store?
Right.
It's the same way with healthcare.
Right.
You're looking for the best bargain, the best quality, the best look, the best fit for the best price.
Right.
It's healthcare. We have to see it the same way. There's no set way of either you have insurance or you don't. And if I have insurance, I'm getting good access and great care. They're not synonymous anymore.
True.
If you haven't noticed,
True.
deductibles are going up,
Right.
premiums are going up, coverage
Coverage
is going down.
Yes.
Well, this is a good response. It's not the only answer, but this is a primary response to that.
Right.
Here's a way you can say, you know what? I'm not going to be a victim to this. I get what's going on, and I'm going to work within that and make sure I have some insurance. But I'm also going to make sure I got good quality of care. I'm not going to get lost in that shuffle of now doctors are having to see 20 and 30 patients a day.
Right.
And here we see 12 to 15.
That's what I was going to ask. You've got to have probably a lot less patients coming through here because you give them more time.
Because you give them more time, you give them more attention. And patients, why not? They deserve that. Because what we've learned, even as physicians, if we're able to dedicate more time as a whole in general, oftentimes you can find out what the root of the problem and not just write a prescription. Most people are looking for you to show that kind of attention.
Right.
Not everybody wants you to write a pill for every little thing that goes wrong. But that's what you're left doing if you don't have the time to get to the root of what the concern is and how to deal with it. In this setting, we have the time to sit and talk about alternatives. The first choice is not always going to be a medication.
Right.
But unlike before in a traditional setting, I didn't have time to sit and talk to you about that. If I'm sitting in a 15, 20-minute slot, let's get to the problem. Boom, here's a script. That doesn't work.
And that's what it feels
later.
like when you go to the
That's
doctor.
what it feels
you
like.
know, you're in and out. They got this little shuffle that they give you. You go get your blood pressure, put you in a room, and then bam, 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 the doctor's boom, 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 and then here's your prescription.
Doesn't work like that.
Okay.
Doesn't ever have to work like that here.
Yeah.
You come here, you barely see other folks sitting here in the room with you.
Right.
There's no double booking folks on top of one another. Your slot is your slot. Your time is your time. It doesn't matter if you want to come in and talk about one item or if you literally got 5 things you need to deal with. We have the time slot to address that. And as a result, you feel confident and reassured, my doc's actually listening to what I have to say for a change and not just going by what the book told them to tell me. So that's the beauty, again, of this model. This model has so many benefits.
Sounds like it.
People will sit and go, are you serious?
And the name of this model is direct care.
It's direct. Some refer to it as direct care.
Okay.
It's also known nationally as direct primary care.
Direct primary care. Okay.
Literally, for those interested, you can Google direct primary care and you'd be amazed at what comes up in terms of the definition, the number of practices that are growing across the country. Doctors are finally going, this is a better way to take care of our patients. There's nothing wrong with keeping up to date with current technology, current ideas, what the current studies recommend in terms of treating patients. But what should never have changed is the old way that we really reached out and took care of our patients.
Right.
That being
like the house call.
Like the house calls.
Okay.
You know, if patients have a specific issue and there's something that won't allow them out in special circumstances, you know, I have some older patients that if push comes to shove and the family can't get them here, then guess what? They get a house call visit. That's unheard of, but that's an old way. It's an old way, and it worked very well.
Right.
Because you'd be amazed what we learn from each other when I come to your house.
Right.
As opposed to here.
In the atmosphere is totally different. So you see,
you see a lot more. And anything I'm able to see and learn about you, it helps me take better care of you. Right. That's at the end of the day, the more I know about you, what your desires are, your goals are in terms of your health, your stressors, the better job I can do taking care of you. I can literally say, I bet you we can fix this. I had one patient that I knew part of her issue. She wanted something very particular to happen, but her family wanted her to do this other thing. And I didn't have to say a word, but I knew her well enough to say, you want to do X, Y, Z, don't you? And she dropped her head. She's like, I kinda, yeah. Because her family really was pushing for this other. So literally, because it was a different way of caring, that family was in the room and she was in the room. We're sitting here going, what's a good compromise? Mm-hmm. And what am I okay with in terms of your health? That you can live with and your family will be okay.
Right.
That doesn't happen in a traditional setting.
Right.
There's no time for that meeting of the minds.
Right.
So this is a beautiful way to do it. We're a lot more satisfied at the end of the day, and the patients walk away going, "Oh my God, yeah, why hasn't it been this way for a long time?" So
now, when you started your practice and started that training and going towards medicine, did you look towards direct care?
No.
Okay. So you stumbled across it. How did you
fumble into it, if you will?
Right.
Yeah. No, I started out as a traditionally employed physician for a big hospital system. All bright-eyed and bushy-tailed going in, thinking, oh, wow, I got a good salary, life is good, this is what I wanted to do, I wanted to be a doctor. At some point, very quickly, probably within the first year, I started thinking, oh my God, this is getting a little overwhelming. But maybe I just need to get used to it, let me get a feel for it. And as time grew, and the more I grew accustomed to what was expected, the less I liked it. Yeah. So I slowly, in the back of my head, didn't know that potentially I might walk away, had no idea what direction to go in, but literally was at a point that I said, if I can't make things better and do them a little differently, I may not stay with medicine. That's how serious it had gotten for me. So I started going to various conferences, and I started talking to other colleagues. And as I reached out, I found the first thing I learned about was concierge medicine. Okay.
All right. And so another one there.
Yeah. So when people hear about concierge from a layman's standpoint, the one major difference between concierge and direct care or direct primary care is the way that they pay. Concierge physicians file insurance as well as have a small percentage of their patients that are pulled over to the concierge side. Okay. So the concierge aspect of their practice is direct care. Okay. But the patients have to pay more for concierge because those doctors are also seeing their traditional insurance.
So it's kind of a hybrid model.
It's kind of a hybrid model. That's when you hear concierge and direct care, that's going to be your difference. Okay. The other thing you should automatically think when you hear those two terms is concierge is automatically, on average around the country, going to run you anywhere from $1,500 to $2,000 a year. Okay. That's on average. Most direct primary care practices will run you approximately $700-800 a year. So significant difference in cost. Right. And the reason is direct care docs don't have to worry about pulling finances through their insured patients. Right. Because they don't use insurance anymore.
So obviously their overhead is down.
The overhead is right. They're very lean.
Encoder, they don't have staff dealing with
That's
claims
why
all
more
day
people
long.
are paying attention. Okay. Because they're thinking, in this effort to get healthcare costs down, why not go with a leaner system? And that's what this presents. This presents leanness and this presents transparency. Right. So in doing that, you're able to drive those costs down if we keep things very transparent. So when I'm saying all that, going back to, that was the first model I learned about outside the traditional setting. So then it trickled on down. I learned a little bit more about the real hybrids, because true hybrids are DPC plus insured. They still offer that true cost, but they have even fewer of these insurance patients to be able to do that.
So the ratio is different.
The ratio is different.
They got more decent.
And that's because of the financing of it.
Gotcha.
So, and then finally there's direct primary care who says we're just not going to deal with any of the insured policies at all. With the notion that we want our patients to have some insurance coverage because you do need it in place for when you really need it in place. Right. So bottom line is, what was funny about the whole development is I remember when I first left residency, and one of my attendings, very wise gentleman, he'd say, you got to figure out what you want to do when this is over. And you're looking at him thinking, I want to be a doctor. What are you talking about? This is what I want to do.
Right, that's what I'm doing.
He goes, no, 75% of you, when you leave here, you're not going to keep the first job you have. And we're thinking, yeah, right. We're going to get out, get these great jobs, we're going to keep them. And he proceeded to tell us about different things other alum had done when they left the program. Well, one of the alum, as I later find out, is one of the gurus of direct primary care. He was one of those that went out and did it before it became a thing. Okay. And he had stepped out, and I remember this attending telling me the story about this gentleman, and I went, who in the world does that? Right. You can't make any money doing that. Down the road, as I begin to attend all these conferences, I keep running into this one gentleman. And I listen to where he came from. I was like, That's the alumni.
Uh-huh.
That's the gentleman.
Right.
So sure enough. Anyway, bottom line is he now serves as a mentor to me.
Okay.
We ended up talking, communicating, and he says, yeah, I did it 16 years ago. I've never looked back. And he said, here's why. And he tells a very similar story to what I told you earlier in terms of I don't have any distractions in terms of my patients. Doesn't matter what status they are when they come in, they all get the exact same care.
Right.
And that's the way medicine should be.
Right.
He says, that's how I know I've been doing this thing right. And that resonated with me.
Yeah.
As in, that's it.
Right.
That's my out. And so as a result, I prepared myself to leave that traditional setting, did as much research as I possibly could, and decided, we're going to step out on faith, and we're going to try this and see what happens. And here is Cross Care.
Right.
Yeah. Hence the name came from. I will kid you, was across the street at the light.
Okay.
And the name I wanted, I'd already checked with the state. The name was taken.
Okay.
And I was like, man, I was all hyped, had my name all down. I said, yeah, that's going to be perfect. And they disappointed me and said, so I sat at the traffic light there one morning. I was like, Lord, I don't know what the name of this practice. My name ain't there and I don't have it. And then it hit me. It's like, you have to cross.
Uh-huh.
You have to cross.
Right.
Cross and care. Why not?
Yeah.
And that's how it
direct,
literally can. And direct,
yeah.
so that it's because again, my mentor put on the direct part because his thought was, I feel that direct primary care, it's a movement. Mm-hmm. It's a movement that we have to embrace if we're going to make some improvements to the healthcare system. It's not the answer to all, but it is a very clear part of what the solution is going to be about. And that's transparency, and that's access, and that's the reassurance that, hey, I have a doctor that truly cares about what I am and not what I bring to the table. Right. And that's the best way to describe how this model works.
That's amazing.
Yeah,
that's amazing.
I'm telling you.
Yeah.
It warms my heart every day.
Right.
It's like, yes.
Yeah.
This is the way it was supposed to work.
And unfortunately, I'm sure the insurance companies don't like it.
Yeah, they don't. And
because that cuts their margin. I mean, they still get the tragic care.
Yes.
But they probably make their money, I'm sure, off the little doctor's visits and,
And the way we're trying to appeal to them as a group is that ultimately, don't look at it as we're cutting into your first line. Mm-hmm. Look at how much savings we have on the bottom line.
Right.
And what we're going to do, because these patients can get to us so readily and so easily, we're keeping them out of those emergency rooms where the costs are much more for those insurance companies.
Right.
We're keeping them out of the hospitals because you're going to pay more for that. So it's very hard, obviously, to change that mindset. Yeah. But that's how we're trying to appeal to them. We're not trying to replace you. We never could. Right. We can't afford to do it. That's not what we do. But we think, complementary to insurance. Mm-hmm. And we are part of that problem to put insurance on board with us gives patients the best access, the top quality, the most cost-effective way to have great primary care plus coverage when they really need it. Mm-hmm. So that's how it's been a challenge, but that's how we're trying to appeal to the insurance companies as well as employers. Many of these employers who, same thing, they look just like the individual person and go, what in the world is that? Yeah. How can I be assured that you are going to offer my employees good quality health care? I don't know what this is. I don't even know what this is about. Right. So we currently have some efforts of working on a bigger scale with brokers and some others who are willing to service in terms of volume as opposed to saying my commission is going to come off of me selling that bigger, more expensive plan. Mm-hmm. We want them to get into the interest of who they serve. Mm-hmm. The employers that are coming to them saying, build me a good plan. Right. Something that I know I can rest assured folks are going to be taken care of. Right. And the cost of insuring employees is growing. Mm-hmm. Yeah. So employers are looking for other ways.
Every year.
So we're trying to reach out and say, brokers, hey, we're here, guys. Learn about us. Research about us a little bit. Right. This is a good way to build a plan for your employers. Right. There are some areas of the country where they're putting this together where employers have huge cost savings because they've decided to say, what is that again? Yeah. Let's try that. Let's give that a shot one year. And they can't believe the cost savings to the company. And the employees are more than satisfied. They're like, We've recently been to a conference where they talk about there's a hospital system that jumped on board. Wow. That said, we kept looking at that and we kept thinking, how are they doing that? And they decided to do a pilot 1 year with the employer, with a certain percentage of the employees.
Uh-huh.
And they're like, now we're changing everybody over.
Right.
There's no point in paying all this money when our employees are more than satisfied with going through direct primary care for their primary care services.
Right.
As long as we're providing them with catastrophic coverage through traditional insurance.
Right.
They're like, and it's a huge cost savings to the hospital system.
Right. Right.
But people think it's too good to be true.
Yeah.
No, there's nothing too good to be true about it. It's very simple and very basic. We don't have to put all these extra and put that little fluff on it.
Mm-hmm.
It's a very simple way of doing business. It's a very simple way of providing health care. And most important, it brings transparency back to the table. That's where we're going to make that difference.
Mm-hmm.
It's one of a few industries where transparency is almost taboo.
Yeah.
That just doesn't make sense.
Right.
I mean, not when people
Not
are
when I'm
losing
dealing
their
with my
homes.
health.
Right.
Yeah.
The health, and people losing their homes because catastrophically they don't know, they thinking they're walking out with $1,000 bill and they end up with a $10,000 bill.
Mm-hmm.
It's so unnecessary.
Right.
This is so easy in terms of how to handle that.
Now, you mentioned something that was pretty interesting about the employer and the plans.
Mm-hmm.
Obviously, there's no network.
Right.
There's no PCP or, all of that. So in that situation, how does an employer give their employees a list of people? Do they send them to a website? Is there a central location where all, the direct care physicians are located?
So that's in the works.
Okay.
That's there are some listings like that.
Mm-hmm.
And many of them come from dpc.org, Direct Primary Care Journal, Access Health has a list of DPCs across the country. There are a number of them where you can go directly and it will give you a list of direct primary care physicians in the country.
Okay.
One of the things that's happening with this movement is in various segments of the country, we're coming together as DPC docs saying, let's form these alliances.
Mm-hmm.
And we're having a discussion about what if we were to come together, we each keep our own practices with our own separate names, but we serve as an alliance so that if an employer is looking to see how many places or how many physicians will be available for my employees,
right.
Where can they go?
Right.
And if we settle this alliance along the terms of we all are going to be offering this standard of care,
mm-hmm.
this level of services, then that employer will comfortably be able to say, yeah, I'm going to go with direct primary care with Dr. Harris, with the reassurance that I can go and see Dr. XYZ down in Savannah,
mm-hmm.
And receive the same level of care.
Right.
That's what's being worked on now in various regions of the country.
Okay.
And that seems to be expanding very well right now in the Midwest and the Northwest.
Okay.
So we're working on it here in Georgia,
mm-hmm.
As well as some of the surrounding states.
Right.
But that's in the works, that's in the making. But if it's someone that says now, I'm really curious to do this now, because I will tell you, most of us provide corporate rates. So it's more than reasonable if you're sending X number of employees over to get them covered for a fraction of the cost, tag on a catastrophic plan so those employees are covered,
mm-hmm.
and it's huge cost savings to the employer.
Right.
You could do that now literally by going to some of those websites and, hey, direct primary care doctors. Google it. You can just Google that even, and there are multiple listings that come up. There are several companies, one right here in Metro Atlanta,
mm-hmm.
that has a list of direct primary care offices across the states.
Mm-hmm.
So there are a number of resources to do that. But again, most employers are reluctant to try and seek through this.
Right.
Hence the reason we need to get the brokers on board so that they're able to best describe what they get, because you want to make sure you're comparing apples and apples
mm-hmm.
whenever you're looking at policies for your employees.
Right.
So again, that's part of this movement of let's get them in the conversation. Let's get them to the table, and that's already started.
Okay.
In terms of let's get them to understand why this is beneficial, and don't look at it from the fact that yes, maybe I sell a plan that's less expensive and my commission is less, but look at it from the standpoint, but I'm going to sell more of those plans
mm-hmm.
because
the
person
volume.
You're serving, right? It's going to be a volume issue.
Mm-hmm.
But again, as we know, changing those habits
right.
and that mindset, it's going to take some time.
Right.
So that's where we are in that process.
Okay.
Yeah.
Then finally, as you were talking, I thought of one other thing.
Mm-hmm.
Somebody who's coming up and thinking about being a doctor, or somebody who's going through residency, or even a child who's saying, I want to be a doctor when I grow up.
Okay.
What would you recommend the route that they take to get to where you are now? Should they go the regular route like you went through, residency, and then going through, working for a big company, or can they jump right into direct care? What's the trajectory you recommend they take?
And so, I will say my journey is a little different. This is second career for me.
Okay.
So, I left the U.S. Postal Service to become a physician.
Okay.
A little non-traditional.
Okay.
And so with that said, it takes all kinds. There is no specific path to follow. The younger you are, you follow that path to determine, do I really want to do medicine? That's the biggest deal, because at the end of the day, going through college, finishing college, going through X number of years of medical school, and then going through X number more years of training as a resident, that is not something you're going to want to do on a whim. And you will not stick with it if your heart is not truly into it. If it is not your calling, forget it. You will quit on a drop of a dime.
Right.
They have too many mechanisms in place to weed out. So with that said, obviously the younger up you go, you follow up, get yourself into college, decide what you want to major on. And keep in mind, you don't have to be a science major. I've met many colleagues that have majored in a number of other things way off the beaten path, but decided they wanted to go to medical school, so they made sure they had the additional coursework, which were prerequisites to get into medical school. So already be prepared for 4 years of college. Already be prepared for 4 years of medical school. There's no getting around that. What you decide to do after that obviously depends on what you grow an attraction to in medical school.
Okay.
In terms of the specialty.
Okay.
So I will tell you.
So that's where most doctors kind of figure out.
Right, they figure it out, and that's because during the latter 2 years of medical school, you're spending more time in clinics and hospitals, getting a taste of almost everything that there is out there.
Okay.
That's where you develop that love, or not so much love, for certain specialties. At that point, you have a couple of options. You can say, you know what, I'm going to follow the traditional path. I'm going to get into residency and get out, and take a standard job with the hospital systems. Excuse me. That's where the vast majority of doctors do, young doctors. That's the course they normally follow. I will tell you that is slowly kind of changing a little bit. As was represented in a meeting, I was just in a meeting full of Georgia direct primary care docs 2.5 weeks ago. One young lady just finished residency, and she said, I don't think I can do it.
Yeah.
She immediately says, I've been researching direct care. I think that's where I want to go, but I'm a little afraid. I don't know how this is going to work. Another one is in residency and will not finish until June. She's already decided. She's already putting together her practice. She has decided, I want to follow the path where I go directly into it. I will tell you that is a harder road to follow because you're coming in from scratch. You're brand new. You're already putting the burden of, hey, I've got to make this work on my own.
Right.
You've invested a lot of you into it, and you're hoping that with the help of your colleagues that you make this successful. So that's probably the road less traveled. It doesn't mean it's not possible. The more typical way to do it is to go out, accept a position, whether it's through an employee hospital system, or as I've recommended to somebody recently, come out and do what's called locum. And locum is basically a temporary doc. So you're not committing to anybody for any extended period. It pays fairly well. It would depend on your home setting as to whether or not you need certain benefits, because they typically don't come with benefits.
Okay.
So that has to be calculated into what you're going to make.
That's why they pay well.
That's why they pay well. It pays better because you got to go get your own coverage. You got to go get most places your own malpractice. You got to get all these other things.
Okay.
That's a great way to go, though, because what it does, it gives you an opportunity to explore all the different ways that there are to do what you do. And so you could agree that I'm going to take a job in a standard outpatient clinic. Nope, I'm going to take a job in a hospital setting. Nope, I'm going to take a job maybe even through another DPC doc that temporarily needs somebody.
Okay.
Nope, I'm going to take a job in an urgent care. Nope, I'm going to take a job up in Timbuktu, Alaska. It lets you explore so that you get to see without any long-term commitment what's out there, what will work for you, and what absolutely is not a part of your DNA. That's a great way to start if you really are afraid to commit to any one thing.
Right.
And with that said, you do that for as long as you feel comfortable doing that. You do whatever research you need to figure out what direction to go in. And then you pull the trigger and say, I'm going to go direct primary care. Or, nope, I really see how this works now. I'm going to go into the traditional setting. So it just depends on how it goes. I will tell you now, a large number of the younger physicians coming out are very dissatisfied. And it has a lot to do with the fact that non-medical folks, the bean counters, if you will, are dictating how you see patients, how long you see patients, and what you can see them for.
Right.
And most of us will tell you we did not go to medical school for that.
Yeah.
And so it's very frustrating. They feel that their care is inept. They're not having the time that they would like to have with these patients, just as I've described to you earlier. They don't have that. They're in 15 and 20 minute time slots. Keep in mind, it's already taken 5 or 6 minutes to get the person to the back to get the vital signs. So now
that's part of the 15.
That's part of the 15 to 20 minutes.
Wow.
So now sometimes you're left with between 8 and 10 minutes to actually discuss an issue with your patient. Hence the reason when you go to your doctor's office, oftentimes they'll tell you, all right, son, we can only talk about one issue, 2 if you're lucky, because they've got to get you in and out because there's a whole waiting room.
There's a whole waiting room of people
that's got to be seen.
Yeah.
And remember, their incentive is the more of these I see, the more I make.
Right.
Or the company's incentive, the more of these you see, the more I make. Versus when you come here, the money's already been paid through your monthly or your annual stipend. So it doesn't matter if it's 1 issue versus 10.
Right.
It's to my benefit to keep you healthy, keep you out of here, so that you don't have to have any specific issues and it doesn't affect my bottom line one way or the other.
Right.
That's one of the things that's critical, and newer docs are getting smarter and wiser about. They're looking at what's going to be the demand, what's going to be the pressures if I do it this way versus this way. Don't get me wrong, going into direct primary care comes with risk.
Right.
Because you're literally probably starting from the ground up. There's a handful of us that were able to break away and take patients with you. I wasn't one of them.
Yeah.
I had a non-compete clause. And most doctors do.
Right.
So you're literally starting from scratch. You're starting on that faith that, okay, I'm going to be able to convince folks, hey, this is an ideal way of doing it, with the notion that they understand this is unique. So they're going to look at you as though you have that third eye.
Right.
But it's up to you to sell who you are, and it's up to the patients who will serve as personal testimonies. When they experience what goes on here in this office and the way in which it's handled, they truly are the best in terms of word of mouth. They will go back and tell, oh yeah, I'll never go back to, no, not at all. I had a patient not long ago. He became eligible for Medicare. He said, but doc, do I have to? He literally did not want to leave the system.
Right.
And we explained to him, no, you don't have to leave. You can still utilize Medicare, just not in the office. But when I send you out somewhere else, if I need to send you to a specialist or you need to go get your x-ray, you can use your Medicare. That's perfectly okay. You just don't need it here. We get to do what we need to do here.
Right.
And you can feel reassured that we're taking the best care of you.
Right.
And that's all most docs want. Even the newer docs coming out, they're looking for a way to satisfy that desire to help folks. And unfortunately, the current system, the way it keeps pushing you through, the way it keeps demanding that you enter metrics into the computer while the patient's sitting there and all you're doing is this, instead of talking.
Yeah, or you're talking to their back.
You're talking to their back.
Yeah.
It's the demands of the way the current system sits. This allows them to get away from that. And they really, truly feel like they're back to practicing medicine. So there's no set way for anyone to follow this path. You have to sort of find your own way. There's certain standards that have to happen: college degree, medical school, residency. Those are a must.
Okay, so you got to go those routes.
You got to go those routes.
Okay.
And it'll vary depending on how you do it in terms of how many years. But college likely is going to be 4 for most people. Med school is going to be 4 for most people, unless they're adding on a master's degree. Very popular now is to do a 5-year program where you get your medical school degree as well as either an MBA or an MPH.
Okay.
And then those you're not getting past. And then residency will vary anywhere from 3 years, sometimes up to 7 or 10 years, depending on the specialty.
Right.
So those three sessions you cannot skip. That's the law.
Yeah.
That is the required training of the profession.
As a customer, I feel good. As a patient,
knowing that I have that many years behind all of this.
Yeah.
So and so what they decide at the end of all of that is what dictates whether they decide to go directly into direct primary care,
right,
or tread those waters carefully and go with a traditional setting, or go out here on this locums path where they sort of get to taste and feel a little bit of everything, without the benefits of some of the perks that come with that.
Right.
So there are multiple ways to accomplish that, and then at the end they have to sort of figure out how they want to do it. I will tell you again, especially having had that recent meeting with the Georgia DPC docs. They followed a number of different paths. There were, again, I told you, one in the room that just finished residency, one still not done. Most of us have been in the profession for a few years. I will tell you, most of my colleagues have been out there at least 10 years.
Okay.
I was one of the newer ones in the room. I'd only been out there 3 years when I said, that's it. I can't do it anymore. So it really does depend on how you kind of get to that point. Others had other types of practices and they broke away. Some formed urgent cares and then decided that wasn't quite it and kind of moved on over. There are a number of pathways to get there. But it's all about deciding what you as a provider are comfortable doing and what level of care do you want to offer to your patients?
Right.
If you're okay, don't get me wrong, if you're okay seeing the 23, 25 patients a day and you're able to get through it comfortably and your mind is all right and life's good, you do it. There's a place for everybody. But for a lot of new docs, especially the newer docs, they want their lives. They want happiness in terms of their personal lives. They've committed a lot of years to that training.
Right.
They don't want to have to spend a whole bunch more years struggling.
Right.
In terms of not being happy with their career choices. So, yeah.
Well, you have absolutely blown my mind on how this whole system works. I mean, I had no idea. Even in our weekly meetings that you give us some nuggets every week, it's still not encompassing everything that we just talked about. That is absolutely amazing.
And that's why you hear in some of those meetings, even though I talk about very real illnesses and conditions and how I handle them, but you'll notice it's somewhat unorthodox about a lot of the ways that I handle some of the things that I do.
Yeah.
Because the setting provides that.
Right. I'm
able to actually go through and do that. Yeah, and you missed the one last week where, and I don't remember, you might have been there, I don't know if you missed it the first time where I did the plates.
Yes.
So I redid it.
Okay.
But last week I redid it in terms of the different diets people like to try. And
so
each person had a diet and you had to lay out what your diet would be and what kind of food you would eat. And I did all that to prove the point of, here again, this is a traditional segment that a patient may have. It's a very real session that a patient will come in and say, look, doc, I don't know what to do. In a traditional setting, no doctor is going to have that time to sit down and sort of walk through that process.
And almost meal plan with you.
And forget a meal plan. They're going to refer you to a nutritionist. They're going to tell you, go see your personal trainer or whoever at the gym. And that's going to be your set of generic instructions. Versus this is one very real of, I know exactly what your health issues are. I know what your goals are. I know what your concerns are. We can go through maybe 3 or 4 of those top diets that you're considering and tell you why I think this one's better or this one's worse. There's time in that setting. Something very unique that you don't get in a standard setting. Who does that with the doctor?
Yeah.
So that's what makes this... You hear the snippets, but the snippets all derive from very real cases of folks that come through and the manner in which we're able to handle them, the creativity that we can use to get people to understand what works for them.
Right.
You don't get, my one bill fits all, speech because you're very unique and person so-and-so is very unique and they like that. We reach out to them and we meet them where they are.
Right.
So it works wonderfully and we tend to get much better responses because of that.
Yeah.
They don't feel I've ran them out. Yeah, go lose some weight, go exercise, the same old cut down on your fat, cut down on your sugar. Yeah. Those are generic statements.
Right.
Now,
what about me?
Because if you were me and I was the patient, I need you to tell me how.
Right.
I feel better if you explain to me how. And maybe you even come back to me and say, I can't do that. And that's very real. I need to know that. So we can figure out what can you do.
Right.
Here's how we're going to get you where you need to be. So here's what you can do. I had one patient who said, I'm not giving up rice. She didn't care what I told her. She was not giving up rice.
Yeah.
And then
you could adjust. And
I can adjust accordingly instead of her sending her out saying get rid of the starches, not knowing she was never going to give up rice.
Right.
So it makes a huge difference.
Defeat that, hey, I couldn't accomplish it, now I'm just throwing the towel.
And here I am. I'm a doctor frustrated because you didn't listen to what I told you in those 2 minutes.
Right.
So.
Right.
Yeah,
right.
Exactly.
Yeah.
So that's the beauty of what this is.
Right.
And the reason I'm able to give those little tidbits about how this works and why it works so very well.
Right.
Yeah.
Anything else that we should know about direct care? And if not, wrap it up and tell us about you. Your practice, how we get in touch with you, how you set an appointment, how you get information about getting on the plan, bring all that to a close.
So in terms of just anything else, I highly encourage you to go research the model. It doesn't have to be Cross Care Direct right now. I want you to research the model because I like informed patients. I want patients informed so that you can decide what's the best way to put something together to cover health care or health services for both you and your family. So that's first and foremost. Research the model online. Just Google direct care or direct primary care. The other thing I recommend, obviously, go to our website, which is www.crosscaredirect.com.
Okay.
On that website, it gives you an idea of how we got here. A little bit of the background that we talked about today, how I came to the conclusion that this is a very good way to care for you. It also gives you an idea of deciding whether or not this is a potentially good model for you and your family. In addition, it lists the plans that are there, the cost
Okay.
of what those plans are, and a generic overview of what's covered under those plans.
Mm-hmm.
If there are additional questions, almost always call the office here. The office supervisor, Chanel, that's the other beautiful thing. There's not a lot of turnover in the office. So you get to know the two people
Mm-hmm.
that work here in this office. So you can literally call her and ask her any questions. And no question is stupid. It's whatever, hey, how does this work? Wait a minute, do I get to pay this? So you can pick up the phone very easily. The other offer we have for any potential patient is anyone is entitled to a free 15-minute consultation. So you can literally come in, call, schedule, whatever the case may be, to the office and say, I don't know much about this. But again, I don't even know if I'm going to like Dr. Harris.
Right.
You can come in for 15 to 20 minutes and we sit down and we go over whatever's wrong with you, whatever your concerns are, whatever your goals are, and you get a feel for. Once you see the place, you visit it, you get to decide whether this is a good fit for you and your family potentially. And very easily, you can always reach out to us. We're here in Tyrone, 56 Carriage Oaks Drive, Tyrone 30290. And again, you can call us at 678-827-9799, and we'll gladly answer any questions that you have.
Awesome. Great information today. Thank you very much, Dr. Harris, for sharing the model, sharing Cross Care Direct. I hope you guys got some real good information. I hope you come see Dr. Harris because this is a wonderful model and the office is beautiful. So come see Dr. Harris, Cross Care Direct. Take a look at the comments. I'll have some links to her website, address, and everything like that. So thank you.
Make yourself at home. Find a new family.
Thanks again, Dr. Harrison. Do you have a little motto or anything that you like to share about Cross Care Direct? Something that
yeah, like keep in mind when you look at us, again, we focus on your care, not your coverage. That's the most important aspect of Cross Care Direct.
There you have it, Dr. Harris, Cross Care Direct. Thank you very much.
Appreciate it.
All right.